Thank you, Sue. And first of all, I want to apologize for the wrong title slide, but we are going to talk about tension type headache tonight. And I am the director of the headache clinic at Baystate. We now have 4 providers that do headache, and I'm happy to say that I think the level of headache care at Baystate is markedly improved. I have nothing to disclose. I'm just a neurologist and teach at UMass Baystate. I came from Boston Medical Center, and that's the picture that you see there. In the city, there are a lot of people with headache, and I thought that maybe if I moved outside the city, it would be less so. But unfortunately, that's not the case. There's just as much headache no matter where you go, and tension type headache is pretty much seen everywhere. I think if we were, Baystate looks a lot like Boston Medical Center. It's actually a lot bigger than Boston Medical Center, but it's a lot more compact, which is nice because you can go from one end of the hospital to the other and see your patients without, being exposed to the elements. I think if we were here, none of us would have headache. And this actually is a picture on the island of Cyprus, which is supposedly where Aphrodite, the goddess of beauty, came from. And it really does look like that. It's super peaceful, really gentle waves, beautiful breeze, and definitely conducive to not having a headache. So we're going to talk a little bit about headaches in general, just to get you back into the idea of what headaches are all about. And we're going to concentrate on tension type headaches, and we'll talk about medical treatments, and we'll talk about other approaches. And we're also going to talk a little bit, and if I get a chance to, I'll demonstrate to you some techniques to actually treat your tension type headache. So it's a big problem. It's about 5% of the population here has chronic daily headache, close to 16 million people. It accounts about 20% of phone calls and messages in our clinic in particular. And if you looked at it from a financial standpoint, it accounts for more medical care than stroke and heart attacks combined. That's really a pretty impressive number of folks that are suffering and having to go to the emergency room and having to seek medical care. And always the problem whenever you have a headache is, what is this? Is this a migraine headache? Is it a sinus problem? Is it a tension headache? And what's the treatment? And how do you go about it? And a lot of times patients really feel lost. And to be honest with you, sometimes some of the providers feel lost because there's not a lot of education in primary care on headache management. A lot of the primary care doctors sort of tell me, I know how to deal with acute migraines. I know how to deal with simple migraines. I know how to prescribe triptans, but beyond that, I don't really know how to deal with your chronic daily headache, and I don't even know how to approach the workup. And that's fair, because that's not necessarily what they need to deal with. They need to deal with things like high blood pressure and high cholesterol and things that I don't have to deal with. So to remind you, there's basically 3 buckets of headache. The first bucket is what we call primary headaches, and that includes tension headaches, but mostly migraine, and these other unusual entities called trigeminal automatic cephalalgias. And the best known of those is cluster headache. Now, a lot of people come in saying that they feel like they have cluster headache. Cluster headache is actually really uncommon. And in order to make a diagnosis of cluster, you need to have tearing of your eye, runny nose, redness, and a whole bunch of other things that aren't just that your pain clusters around the eye. And a lot of times you have to explain that to people, but they're pretty darn uncommon. The secondary headaches are things that have an underlying disease process that causes the headache. High blood pressure that's out of control, increase in pressure inside the skull, Probably the most common one is caffeine-related headaches and alcohol-related headaches. Certainly, if you have bad meningitis, that can be a big problem. Certain metabolic conditions, having really low blood sugar, being dehydrated, can produce headaches. And psychiatric issues can produce headache. And a lot of medications that people take for other conditions in and of themselves can produce headache. And then there's a different kind of head pain altogether that has nothing to do with headache. And those are nerve issues that affect the face. The most familiar with that you may be familiar with is trigeminal neuralgia, which is a type of nerve pain that affects the nerve that supplies sensation to the face, and it produces shooting electrical pain up and down the face. It is uncommon, fortunately, but it's also very difficult to diagnose. When you look at the primary headache things, how do you differentiate migraine from tension type headache from cluster? And part of it has to do with the age of onset. It also has to do with the gender ratio. So as you can see, cluster is very, 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 very uncommon in women. I think in 25 plus years of practice, I've seen exactly 2 women with cluster. Migraine is much more common in women, and you'll see that it is also much more likely to start in a younger age than cluster headache. Tension headaches can happen at any age, and men and women are equally liable to get it. So that doesn't help you one way or the other. The location of the pain is very specific in cluster. The pain in migraine can be pretty significant, but the characteristic of migraine pain is that the headache, the pain itself, gets much worse with any type of activity. So one of the things that we ask people is, what happens if you get up and go up and down stairs? Does that make the headache worse? And if it does, that kind of points you more towards migraine. If it doesn't, you're kind of thinking more tension. People who have migraine and tension type headache both want to lie down in quiet rooms, but migraineurs really can't tolerate flashing lights. So any type of neon lighting is very noxious to them. Any kind of really loud sound is super noxious to them as well. Cluster patients, in contrast to migraine and tension type patients, are very restless and agitated. They actually have to walk around to distract themselves from the pain. When you look at tension type headaches, they don't have the other systemic symptoms that you have in migraine or cluster. So there isn't really vomiting. There may be some mild nausea if it lasts long enough. You don't have sensitivity to light or sound that's significant and debilitating. And as I pointed out before, it doesn't get worse with physical activity. Cluster is a whole nother thing. You see teary of the eyes, you see a runny nose, the face can be swollen, you can have eyelid drooping, and you can even have pupil changes. In terms of time, cluster is brief. It lasts about 15 minutes to about 3 hours at most. Migraine can last up to 3 days, but tension type headaches can last weeks. And a lot of people find that hard to believe that tension headaches last that long, but they do. And in fact, if somebody tells you that they've been having a headache for a month, it's very unlikely that you're dealing with migraine alone. There is no periodicity. There's no cyclical component to either tension headache or migraine. Cluster has a seasonal cycle. Some women with migraine may develop attacks around the time of their menses, but not as common as used to be thought. And then what about triggers? Alcohol, histamine, heat, bright light, and smoking are triggers in cluster headaches. In migraine, it can be a lot of different things: dietary changes, dehydration, hypoglycemia, being hungry. Um, Patients talk about weather change as a trigger. And there's at least 2 studies that really point that that is, in fact, the case, that when barometric pressure changes, patients can develop migraines. And we still don't understand that fully. In tension-type headaches, the number one trigger to tension-type headache is stress, followed by alcohol, followed by jaw clenching or tooth grinding, eye strain, excessive amounts of caffeine, and fatigue. And when I say fatigue, I don't mean you're just tired walking around. I'm talking about you're really sleep deprived. And you may not even realize how sleep deprived you are until somebody starts asking you questions about that. In the end, we think that all head pain comes from this area here, which is the blood vessels that surround the brain. And what we think happens is that when this chemical, CGRP, is released by nerves, when stimulated, it produces inflammation and opening of the blood vessels. And inflammation and stretching of the blood vessels triggers the pain nerves that supply those blood vessels. And that in turn produces more feedback to the brain, which then causes more release of CGRP, and it becomes kind of a vicious reverberating cycle. So CGRP, we think, is the main chemical that mediates the pain in all forms of headache, whether it's migraine, cluster, or tension. The question is, what is it that triggers the CGRP release? So we think that, at least in migraine, it has to do with a transmitter called serotonin. And serotonin is released in many parts of the brain. It's one of the big components of neurotransmission, and it's very densely supplied by the trigeminal nucleus, which is, again, that nerve that supplies sensation to your face. And we think that in some people, this area of the brain is sensitive to sensory input, whether it's chronic muscle tension, certain foods, certain environmental triggers that produce a lot of firing into the trigeminal nucleus and releases, in turn, a lot of serotonin. And serotonin, in turn, releases CGRP, producing the pain. But as you can see, migraine is very different. Serotonin produces many other things. It affects other parts of the brain. The thalamus here, where all sensory input is relayed, and that produces sensitivity to sound and to light. It also affects the cortex, which is your thinking part of the brain, and the perception of the pain becomes different. People may become foggy. They may develop focal neurological symptoms where they look like they're having a stroke. We don't think that that happens in tension-type headache. And in fact, we have pretty good evidence that serotonin is not really changed in tension-type headaches. So it's a completely different mechanism. You've probably seen a lot of television commercials, and you've seen a lot of articles in the lay press about anti-CGRP monoclonal antibodies. And there's a bunch of drugs that are out there now that are marketed for migraine prevention. And the way that they work is they don't work out in the periphery, which is what I had showed you before, out at the blood vessel area, but they work more centrally in the brain itself and in this trigeminal neuron. There are studies being done now looking at different anti-CGRP drugs for a tension type headache, because in the end, that's the chemical that's involved in all of the head pain, but they're not by any means complete, and they're kind of pointing us in different directions, suggesting that maybe there is an additional mechanism that we don't know about in tension headache. So how do you know you have a tension headache, and what do you do about it, and what should your doctor be thinking about? Well, one of the most common misdiagnoses of tension headaches is that they're sinus headaches. I say this all the time to medical students, and I say it all the time when I give a lecture. Sinus congestion does not produce headache. It produces head pain. It produces pain around the eyes. It produces pain around the sinuses, but it doesn't produce headache. And it does if you're sick and you have a fever, but not just by having sinus congestion. I have terrible seasonal allergies. I get horribly congested. I never get a headache. That is just medical mythology. Do you have a secondary medical problem? One of the biggest things that we see that is undiagnosed is sleep apnea. People just don't sleep very well. They assume that it's because of stress. They assume it's because of a lot of other reasons. But if you talk to their partners and you talk to their family, you hear that they fall asleep during the day. They can't get through a movie. They sometimes space out. They never feel rested. And when that is the case, you really have to consider sleep apnea. So we do a lot of sleep studies, even in tension headaches. Some of the less common causes are low pressure headache, which happens with spinal fluid leak, especially after injury, or very high pressure inside the skull when people have certain hormonal disorders or other medical problems that contribute to that. Other big issues that come up are unrecognized medication overuse. Just today, I was speaking to a patient who tells me that he takes about 4 grams of Tylenol a day for his arthritic problems, and he's been doing that for 2 years. And he's had a headache for 2 years. And as he pointed out, Tylenol doesn't seem to help. Well, not really a surprise, because Tylenol is actually the cause of his daily headache. A lot of the chemicals that go into the over-the-counter medications can, in and of themselves, actually produce headache, and they can produce inflammation and irritation of the nervous system, which leads to head pain. You can have other sleep disorders. Some people have restless leg syndrome that keeps them up at night, and definitely mood disorders. And after COVID, we've seen a lot more difficulty getting to sleep and staying asleep because people are under a lot more stress than they had been beforehand. So again, we're going to now move on to tension type headache, and I just want to review the symptoms. It's a mild to moderate headache. It isn't debilitating. You usually can continue to do what you're doing, although probably not as well. The pain is dull and achy. It isn't unilateral generally, but it can be. And it's usually felt around the head. People talk about a squeezing pain. Now, in some cases, you can have one-sided headache that you notice because some of the muscles are tight on one side. But as time goes by and the headache persists, it becomes more generalized. There'll be muscle tenderness in the scalp, the neck, or the shoulders. And sometimes over-the-counter medications, at least at the beginning, can help with that head pain. And it tends to get worse and be triggered by stress, lack of sleep, and poor posture. And especially, nowadays when we're doing a lot of working from home on the computer, leaning forward over the keyboard, leaning forward into a screen, not getting up and changing your position can all make your muscles very, very tight. So what do you do when you have an acute tension type headache? So the first thing to do is to put ice on the neck and shoulders. And I know that sounds counterintuitive and everybody likes heat, But when you put heat on tight muscles, you end up with hot, swollen muscles. And what you're really trying to do here is you're trying to relax the muscles. So application of ice to the neck and shoulder area causes the muscles to relax. Application of ice to the forehead, the temples, also super helpful if that's where you're having that band-like tightness. You should absolutely stop any work that requires a lot of concentration and prolonged neck strain or eye strain. If you're going to take an anti-inflammatory, and it doesn't make any difference which one you take, they all work equally as well, and most people have found that one works better for them than another. You should go ahead and take it, but you shouldn't take it more than 2 times per week. Once you start to get beyond 2 times per week for more than 2 weeks, you're really going to end up with medication overuse headache. And you're going to convert an episodic tension headache to a chronic daily headache. That works in about 80 to 90% of the time. Sometimes you have to go further and you have to use muscle relaxants, particularly if it's really muscle strain that's contributing a lot to this. But once you start to have chronic tension type headaches that go on for more than 6 months, more than 2 times per week, you kind of probably should be seeing a doctor and looking a little bit more deeply into what could be causing it. Now, other basics are really pretty much directed towards lifestyle changes. And everybody's tension type headache is different. So I'm just going to say that because what works for some people doesn't work for others. And I've heard all sorts of things over the years that people tell me I do this and it works great and doesn't seem to make a lot of sense, but that's okay if it works for them. And other people will have tried all sorts of other things and nothing works for them. So you have to individualize it to the particular patient and to the particular problem that's causing the issue. And a lot of times that's not really obvious on the first encounter. So the most important thing that you can do to avoid tension type headaches and to get rid of them when you start to have them is to get sufficient, and I underline the word restful sleep. You could sleep 18 hours, but it doesn't really count. You have to get good quality sleep. And the reason for that is because there are different phases of sleep. Different phases of sleep do different things for the brain. When the deepest phase of sleep is the one phase of sleep where your neck and shoulder muscles actually get a signal from the brain to stop working. And that's why when you see people fall asleep, their head will go down. That's because that signal from the brain paralyzes the muscle. And when we do sleep studies, that's what we're looking for. So if you sleep, but you don't enter deep phase sleep, which can happen due to medications, stress, bad sleep habits, and so on, it doesn't really allow your neck and shoulder muscles to relax, and you develop chronic tension. And that, in turn, leads to the rest of the type of headache. Once we've gotten the sleep under control, what can we do to make the neck and shoulder muscles relax? And that's a little bit more complicated. You can do massage therapy. You can do deep tissue work. And I would say deep tissue work is by far the most important. Nice, simple massage doesn't do a heck of a lot. If anything, it makes it worse. Mindfulness training to help you relax and to decrease your fight or flight response is also key, because most people can't sleep because their brain is trying to keep them awake. It's trying to keep them protected. We're geared for that. We're not geared to sleep when we're under stress, because back in the old days, that's when the tigers came out to get you, was at night. So you have to really be careful about that. And you can't go from 100 miles an hour where you're doing, you see this in college students, they're writing papers, they're texting their friends, they're on the phone checking TikTok, and then they slam the computer down, put the phone off to the side, turn off the lights, and think they're going to fall asleep. Their brain's still working on all the other stuff that they were doing before. Well, now we all do it. Now we all look at the computer. Now we all watch TV in bed. Now we all listen to podcasts before we go to sleep. And all of those things require cognitive input. And cognitive input is stressful for the brain. And you're telling your brain you're not ready to go to sleep. And it doesn't make any difference if the speaker has a nice, calming voice with a lovely British accent. Your brain is still going to be tuned into what they're saying. And even when you fall asleep, your brain is still picking up that information. One of the worst things that you can do for sleep is to fall asleep while watching television. That is the worst thing that you can do. And yes, I've heard people say that they put timers on their TV to turn it off. The damage is already done. So mindfulness training, reducing your stress and getting into a good sleep routine where you kind of start to tell your brain gradually that it has to get ready and it's okay to do so to go to sleep by removing things that require attention, removing things that require cognitive input, removing things that have your brain tune into it. Done slowly over the course of 45 minutes to an hour before you turn off the lights is really, really critical. Other lifestyle modifications, don't over-eliminate your foods. It's not going to make a huge difference in your headaches. Trigger elimination, yeah, absolutely. If every time you drink red wine, you get a headache, you don't need me to tell you not to drink red wine. That's probably a unique trigger to you. But when you do an analysis of food triggers for headache, whether it's migraine or tension type, it turns out it's really pretty darn uncommon. And most people recognize it and stop. They already know that every time they eat, that they drink red wine, they get a headache, so they don't drink red wine. They know that every time they eat, pizza, because you're gluten sensitive, they get a headache, so they don't eat pizza. Exercise, meditation, mindfulness, we already talked about. What they really do is they reduce your stress response. They reduce your autonomic nervous system. They reduce the problems that keep you from sleeping, and they reduce muscle tension. These are really, really critical. And that allows you to have regular sleep. Now, when I say regular sleep, I told you need to get a few hours of sleep. You also have to avoid interruptions. It's really hard when you have little kids that wake you up in the middle of the night, but sometimes you have to tell the kids can't get up in the middle of the night anymore. I was talking to a patient who told me that she sleeps with 6 dogs, and some of them, need to be walked at 2:00 in the morning. I'm like, well, who's the boss here, the dogs or the patient? I can't fix your headache if you're getting up 2 to 3 times in the middle of the night to walk the dog, because you're basically not sleeping. She goes, oh, well, I sleep. Well, okay, so what time do you go to bed? I go to bed at 8:00. What time do you wake up? I wake up at 5:00. Okay, that's 9 hours. How many times do you wake up in the middle of the night to walk the dogs? 3 or 4. So basically, this person wasn't sleeping more than a couple of hours at a time. That's just really not sustainable for your brain. It just doesn't like that. CBT for stress reduction and for insomnia, that's cognitive behavioral therapy for stress reduction. We do refer people for that, and it can be very helpful. But there are also things that you can do on your own, and there are online programs that you can do to identify the triggers that produce stress and the triggers that make you stay up at night. So I'm going to give you a typical case that we saw in the clinic not that long ago. This is EC. She's a 32-year-old woman, no real medical history, and doesn't take any medications. She recently moved in with her long-term partner, a partner of 5 years. And over the last 6 months, she developed almost daily headaches, which are not associated with other symptoms. And no, her partner is not hitting her over the head, and there's no argument between her and her partner. The relationship is very stable. The headaches are not debilitating, but they are annoying. It makes it difficult for her sometimes to get her work done. She has some relief with anti-inflammatories, but is now taking them almost every day, sometimes multiple times per day. She denies any other work changes. She denies any other schedule changes. She denies any family stressors. She feels that she sleeps about 8 hours per night, but doesn't feel rested, and that's relatively new for her. She has changed her diet. She went, quote, gluten-free, but noticed no changes. And she's very frustrated and wants some relief. So this is a typical story that we would see in clinic, and it's been going on for several months. Nothing really seems to be working. Her blood work is normal. On examination, she has what are called trigger points in the neck and shoulders, but she doesn't have any other neurological findings. And trigger points are these areas here in the neck and shoulder area, and then this one right here around your shoulder blade, where you can feel tenderness in the muscles and you can feel knots. And when you push on them, you will get pain that radiates away from the area where you push, including this one over here. And this one over here is very, very reproducible because it's an area of structural weakness. It's where all the shoulder girdle group and your back muscles and your chest muscles all kind of intersect here. And there actually isn't any muscle here. It's all actually connective tissue, but it's loaded with nerves. And when this connective tissue is pulled by muscles that are tight here, or even up here, these nerve fibers fire and you get a lot of pain, and you even get pain that radiates into the chest and can mimic heart attack. So getting back to our patient, what kind of headache is this? Well, it certainly isn't cluster, and it certainly doesn't look like migraine. And it's been going on for 6 months, and so it's a chronic tension type headache. The other possibility is because she's been taking so much over-the-counter medication is that she may have some medication overuse headache that's contributing to the whole picture. But what else is going on? What happened 6 months ago since her headache started that could be contributing to this? Well, the first thing, pretty obviously, is that she changed her sleep. And when you talk to her about her sleep, what she says is that, she used to go to sleep, turn off the lights, fall asleep, but that now that she's moved in with her partner is a night owl. So she'll go to bed and he'll stay up watching television. And that will go on for several hours. And then he usually falls asleep and she wakes up to turn off the TV and, sort of tuck him in. And then he gets up at least once in the middle of the night to go to the bathroom. And that usually wakes her up as well. So she really doesn't get uninterrupted restful sleep. And that is not unusual. And the other thing that she told us is, sometimes she wakes up in the middle of the night because her partner snores so loudly that it actually wakes her up. The fact that she's using anti-inflammatories daily, we talked about hospital medication overuse, definitely another issue to think about. Now, this has been going on for 6 months. The headache is pretty bad. she's very concerned. Does she need to have her brain imaged urgently? And the answer to that is absolutely no. Anything that's bad enough to cause a headache that's been going on for 6 months is going to give you local neurological findings. And in a good examination, you're going to see them. This lady had an absolutely pristine exam. So it doesn't work that way. Yes, there are all sorts of stories of people who had headaches and it turned out that they had a brain tumor, but they never really have been examined by a neurologist. And it's pretty unusual for you to develop headache with a normal exam in the setting of a mass. In fact, headache is actually probably not the main presenting feature of brain masses. And then, what are we going to do about this? What's the first thing that we can do to help her? Well, the first thing to do, and it seems counterintuitive, is to stop the anti-inflammatories, because at least that's one thing that we know is going to be making a difference for her. And then, whoops, I'm going to go back here. Other things that we told her to do is talk to her partner about his sleep habits, because they're really screwing it up for her. And that can be a difficult discussion to have. Certainly, you can use earplugs. A lot of patients who have difficulty sleeping, it isn't just they who are having difficulty sleeping, it's their partner who's really having the big sleep issue, and it's keeping them awake. So if this gentleman who subsequently turned out to have sleep apnea, is keeping her awake, we told her that she needs to discuss that with him, and she needs to block her ears so that she doesn't wake up with that. And soft, rubberized silicone type earplugs are very comfortable and easy to use. And of course, you can always say, you got to go sleep in another room, or you go sleep in another room because I really need my sleep. Other things that we did for her was give her something to try to break the cycle. So because she was having so much headache and so many anti-inflammatories, and we were telling her to stop taking the anti-inflammatories, we knew her headaches were going to get worse before they got better. So we treated her with a brief course of steroid to try to break the cycle and keep the headache under fair control until she got detox from the anti-inflammatories. And that worked pretty well for her. Once we had her sleeping, and she was sleeping well, her headaches went and got rid of the other medications. Her headaches went down to about 1 a week. And because we knew that she had a lot of trigger points, we referred her to physical therapy and massage therapy, just mostly to show her exercises of what to do. She got a couple of stress massagers and point massagers and one of those thumper massagers, and was doing the massage on her own. And in about 2 months, she was down to about maybe 1 mild headache a month. And we consider that to be pretty successful. I get asked a lot about cannabinoids in headache, and are they helpful? Well, cannabinoids can clearly improve sleep. They are actually time-tested and were recommended in the first modern textbook of medicine by Sir William Osler as early as 1892. They were the specific treatment for attention-type, cluster, and migraine headaches. If you really look at the literature, however, there are no clear definitive studies. There are 2 guidelines from our friends up north that recommend cannabinoids as potentially useful, but and there's one that just came out from the European study group on headache. They can be helpful, but they're not for everybody. And certainly cannabinoids definitely are known to improve sleep, but if you take them in combination with other medications, you can markedly worsen certain types of sleep. In the end, we can make recommendations, but in order to be successful in getting your attention type headache taken care of, everybody has to be engaged. So the patient has to feel comfortable with what you're telling them. The first thing that most people tell me is, well, what am I going to take when I have a headache if I can't take anti-inflammatories? And then the answer is, but it's the anti-inflammatories that are giving you the headache. And do they even work when you take them? And the answer usually is no. So we become very conditioned to taking medication, and you have to get buy-in from all parties about the treatment plan. You can talk about other treatment options. What about things like acupuncture and Reiki and so on? All those things are okay, but there's no particular scientific study that says that they're better than anything else. There are anecdotal reports that they're helpful, but they're not rigorously comparable studies. Nevertheless, people like to try alternative treatments. That's totally fine. And we appreciate that. But I would point out to you that when if somebody is really good at what they do and they have faith in their treatment, they should not be charging you so much money and tell you that it's only going to take more weeks for it to work. I've had patients who tell me that they go to certain therapists and certain kinds of practitioners who tell them that it's going to take 12 weeks for them to get better. And that's at $80 a session. That's a lot of money that insurance doesn't cover. I usually tell my patients, if you want to try those things, by all means do so. But if you don't notice any improvement after about 2 to 3 weeks, which is usually the amount of time that placebo response occurs, I would think twice about continuing them. Once we've talked about what's doable, then you and your providers should come to a decision which is acceptable to both of you. I don't feel comfortable having people, for example, have certain treatments when they have a bad neck. You're putting people at risk when you're doing rapid manipulation of the neck. I don't feel comfortable having people taking sort of unregulated and unsanctioned substances that they don't know where they came from, because the potential side effects may be really dangerous. And then in the end, everybody comes to a decision, you feel comfortable about it, and you go ahead with it. And then in a few weeks, if things aren't better, you got to reassess the picture. And that's kind of like shared decision making. And it's applicable to all areas of medicine, but particularly in headache, because it's very much a lifestyle issue in tension type headache. Now, this is sort of a summary picture here, but I'm also going to show you a couple of things that you can do if you have an acute tension type headache. And I'm not very good at animation, so I'm actually going to do it on the video. When you start to have your tension type headache and you're having all of this pain over here, you're going to apply ice to the back of your neck. You're going to put it on both sides. Bag of frozen peas is perfectly acceptable. You don't need any fancy stuff to put back there. If you can have somebody do a little bit of ice massage to your temples, that can also be very helpful. You're going to back away from your computer screen, and you're going to take 20 minutes where you're going to not look at the computer screen. You're going to close your eyes for about 20 seconds and look away for about 20 seconds, because that restores the tension in your eye muscles. You're then going to do some muscle exercises. The first one that you're going to do is you're going to take your thumbs and you're going to hook them in the back of your skull, where your skull curves about 2 finger breadths in from your ear. So basically back here. And you're going to gently rub until it starts to hurt. And then you're going to rub a little bit more, and you're going to keep it there to a count of 10. And then you're going to let it go. And then you're going to start again and do the same thing. And you're going to do that 5 or 6 times. And that relaxes the muscles that insert to the back of your skull. The other thing that you're going to do after that is you're going to do head rotation. And you're going to take your head and you're going to turn it away and you're going to push against your hand. Some people like to use a towel and pull their head to the side. It's unnecessary. You can do it on your own and just push your head to the side and hold in that position for a count of 10. You're going to feel the tension on one side. Same thing on the other. Then you're going to tilt your head to one side, hold it there for a count of 10, then do the same thing on the other. And then the last one, which is really weird, you're going to stretch your neck and your back muscles, and you're going to try to touch, you can't really do it, but you try to touch your shoulder blades to each other. And you do it as far back as you can, and you hold it there for a count of 10, and you do that about 5 times. The last thing is the chin tuck. You try to bring your chin back and as close to your chest as you can. And that relaxes your jaw muscles and your chin muscles. And you're going to feel tightness back here, but the muscles will gradually relax. That's the quick thing that you can do for self-management right there and then. Chin tuck, head flexion, head rotation, okay? Shoulder movement backwards. Those are the key things that you're going to do. And then the massage to the base of your skull with pressure back there. That's what commercial massage therapists would tell you to do. And that's what a physical therapist is going to do. So none of that, though, is going to work, as I think you understand by now, if you don't get good sleep. Because what happens is, in fact, I don't even send people to physical therapy or to massage therapy until I get them sleeping. Because then what happens is you're trying to stretch muscles that don't want to stretch, and you end up worse. And then you go through your physical therapy benefits or your massage therapist benefits, and you're not getting anywhere, and you just get more discouraged. So we really try to work hard on trying to get people to sleep. We limit the use of anti-inflammatories, strongly encourage ice and self-massage therapy. Occasionally, you have to supplement with muscle relaxers or other medications to improve the sleep and look at things like sleep apnea. But in the long term, the most important thing is lifestyle modification. Sometimes there's nothing you can do. People are working 2 jobs, they have shift jobs. I have a lot of ER physicians who, they really can't change your sleep schedule. So you can do the best that you can, and then you have to manage the attacks when they occur and prevent them from becoming chronic by putting people on medications that help them sleep when they can and avoiding overuse of other medications. That's basically the end of the talk, and I'm happy to take questions. I always like to end with this picture here. This picture is called The Doctor. You can tell it's a doctor because they're wearing a neurologist because they're wearing a bow tie. So the days when we used to sit and listen to our patients and think about what to do, and the only thing we used to have was morphine, and the families would sit around waiting for us to do something, are long gone. There's lots of things that we can do to try to make you better. But in the end, you got to find somebody who's going to listen to you and try to figure out what the problem is. And neurology is very much like detective work. And in fact, Sherlock Holmes is based on a physician who was a proto-neurologist. And we spent a lot of time listening to the story and teasing out the problem to try to find out what the right solution is for you. Thank you for your time. I'm happy to take questions.
Thank you, Dr. Otis. That was awesome. I appreciate that. Great talk. And we do have some questions in the Q&A box already. Would you like me to review them for you, or would you like to? Sure,
please.
Okay.
Sure, I can see all of them.
Sheila would like to know, what are your thoughts on white noise for sleep?
Absolutely great. White noise is a great thing to use. It blocks out other ambient sound. A lot of people like to have background noise, and I think that that's a good thing. You don't want to listen to anything that has lyrics. You don't want to, and if you're a musician, you probably don't want to listen to anything that has any melody or harmony or rhythm because your brain's going to start to try to analyze that. So white noise, neutral noise, they even call it nowadays brown noise, which I'm not really sure where that term comes from, except it sounds like you're sitting in a Starbucks. So maybe from the coffee, but that type of noise is really helpful. By the way, the patient that I presented to you, once she got her significant other to use a CPAP for his sleep apnea, she was sleeping like a baby. And I said to her, "What about his CPAP?" She says, "I love that noise. It puts me to sleep right away." So that was a 2-for-1 winner. So absolutely, white noise is a great thing to use.
Oh, that's terrific. Thank you. Next question. When is a good time to exercise before bed?
Never. The answer is if you're going to exercise and you're going to get your heart rate up, you got to do it at least 3, preferably 5 hours before bedtime. And I know that that's hard for a lot of people. So you want to do it at least 3 to 4 hours before you go to sleep. I'm not talking about gentle stretching. I'm not talking about simple neck rolls or that type of thing. I'm talking about anything that gets your heart rate up. Because once you're starting to get your heart rate up, you're kicking in your autonomic nervous system. And then your autonomic nervous system is going to keep you from falling into deep phase sleep. Now, if you're absolutely, totally, completely exhausted, sure, you'll fall asleep, but you're going to wake up in a few hours because you won't progress to deeper phases of sleep.
Good feedback. Thank you. Next question. Can you define CBT?
So cognitive behavioral therapy is a type of therapy that's geared towards helping you identify triggers that make you develop stress and help you identify your stress response. I'm not an expert on cognitive behavioral therapy. It looks like there's somebody there who probably is. But what I would tell you is that it's just becoming aware of what it is that sets you off and also what tools you can use to dampen that. Because once you know that you're going to develop a stress response, there are things that you can do to keep it from getting out of hand. And that's the focus for most people, practitioners of CBT. All right. Now you caught me. I slept through all those lectures in medical school, so I probably didn't do a very good job defining it officially, but that's the gist of it.
Excellent. Thank you. Okay. Next one. How do you go about getting an official diagnosis? Do you start with your regular doctor? And also, at what point is a headache an emergency?
So I'm not sure what you mean by official diagnosis. Official diagnosis, people don't like to hear the term tension type headache because they say, well, what do you mean? That doesn't sound like it's that serious. And it is. I think I try to explain to you that actually they're the most difficult headaches to treat, and they tend to last the longest, and they affect the most people. If you're ever, I would start with your primary care doctor and give them the benefit of the doubt, try and treat you. But if you're not getting any better, then sure, then it's time to go and ask for somebody else to take a look at you. I would point out that not all neurologists deal with headache. And in fact, in Massachusetts, there are not that many people that are trained in headache management. There is a big headache clinic in Boston, but they're kind of a one and done situation. They see you, they render an opinion, and then they send you off on your way. They don't really do anything different. I used to run the headache clinic at BU for 25 years. We used to have patients referred to us from the other headache clinics because we had an inpatient component to us as well. But I think that there are plenty of people out there now that can do good headache management. And we certainly have it in our area. But you have to feel comfortable with a practitioner. If you don't feel comfortable, then nothing, no matter how good the treatment is, it isn't going to work. In terms of what makes an emergency, if you have what's called the worst headache of your life that comes on full blast at the very beginning and is pretty severe and lasts, that's what we call a thunderclap headache. And yes, that's a big issue. If you have a headache that starts to produce other neurological signs like visual changes, weakness, numbness, tingling that you've never had before. And by the way, lots of migraineurs will have that as part of their attack. But if you're having some of those things and you've never had them before, then you really should go to the emergency room. Headaches in the setting of head injury, headaches in the setting of uncontrolled high blood pressure, definitely an issue.
Thank you. Just a couple more questions here. For head rotation that you were demonstrating earlier, are you pushing your chin back or are you pushing forward against your hand?
Sorry about that. You're turning your head in one direction and you're pushing against your hand as your hand is trying to push it in the other way. So if I'm turning to the left, take my left hand and I'm pushing my chin to the right because I want to stretch this neck muscle here.
Excellent. Thank you. Margaret says I grind my teeth and clench all day long. Can tension headaches cause brain fog along with temporal pain?
So what I would tell you is that if you're doing it during the day, you're probably doing it at night. And if you're doing it at night, then you're probably not sleeping very well. And in fact, it's a chicken and egg problem. You may be having it both that you're not sleeping, which is causing you to grind your teeth, which causes pain, which keeps you from sleeping, and it just keeps reverberating that way. Can it cause brain fog along with temporal pain? Absolutely. TMJ tightness, this is where the muscle goes to your jaw. So if this is being clenched all day long, you're going to have pain right here. Will it cause brain fog? Yeah, if you don't sleep well, you're absolutely going to have brain fog.
Excellent. Thank you. We're just about at time, but we have a couple of quick questions if you want to take those on real quick. Do you look at a patient's medications, prescriptions, and look at alternatives for swapping out?
Yes.
Okay.
But it's very individual.
Right.
One of the more common things that we see is that people are put on what are called sedative hypnotics chronically for sleep. And those drugs actually really mess with your sleep. And it's very difficult sometimes to get people off of those medications because it's not that they don't work, but they actually prevent deep phase sleep. So that can be very challenging. But yes, we definitely look at alternatives and we talk about swapping things out.
It's just 7 o'clock. Do you want to take one more?
Sure, I can take 2 more. That's it.
Okay. Does your office participate in any medication studies involving tension, migraine, or cluster headaches?
So there are actually no studies on tension headache. It's a very heterogeneous population, and it's very difficult to study. Migraine and cluster headache studies right now are few. I've participated in studies in the past. Since coming to Baystate, I haven't, but we certainly will. And we find one that we think is reasonable and appropriate.
Terrific. Last question. What kind of labs are drawn usually for DX? And do you see a lot of cases that headaches are related to low magnesium?
So we draw, it all depends again on the case. In some patients, we have to draw labs looking for inflammatory conditions. If we think it's appropriate, we'll look for Lyme disease. We usually get the basic panel that probably your primary orders to make sure you're not anemic, that you have enough iron in your system. So it's interesting that you ask about magnesium because magnesium is used as a supplement. But if you look at it in terms of predictability as to whether or not it affects people's headache, it's not really reliable because magnesium levels vary dramatically during the course of the day. So we don't specifically look for magnesium. We do look at certain other things like vitamin D levels, and we look at certain vitamin levels. And in rare cases, we'll look at autoimmune panels. But like I said, it all is tailored around the situation of the patient.
Excellent. Well, thank you for your time after seeing patients all day and this great talk and your expertise.
Well,
thank you so much, Dr. Otis.
Thank you all for your questions. They were really interesting, and I hope I was able to give you some helpful answers. And thank you for your attention.
Thank you.